All right, welcome everybody to this iteration of the SMSNA webinars. I know that I talk on behalf of everybody here that we're all very honored and excited to be here to talk about a topic that I don't think has been presented in a webinar format before, and actually doesn't really get enough attention within the SMSNA and the prosthetic community. So we'll be talking today about penile prosthesis considerations in the MSM population. And on behalf of my co-moderator, Chris Nelson, and I can attest that we're very excited to be here. We're excited to have three great speakers who have both either done research or have an interest in the LGBTQ plus community and and special considerations in terms of sexual dysfunction and prosthetics. So our speakers will be Justin Law, Jake Miller, and Dallas Steele, aka Jim Walker. So I'll give you a little bit of a background about our panel. Dr. Nelson doesn't really need any introduction. He is the chief of the psychiatry service and attending psychologist in the Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering. He is also professor of psychology in the Department of Psychiatry at Weill Medical College of Cornell University. And he specializes in improving the quality of life of patients treated with for genitourinary malignancies and older adults with cancer. Of note, Dr. Nelson is the current treasurer and serves on the executive board of the Sexual Medicine Society of North America. Dr. Law is currently a staff urologist at Kaiser Permanente San Rafael Medical Center. He completed his urology residency training at the University of California, Irvine, where I work, and then did an andrology and sexual medicine fellowship at the prestigious Men's Health Melbourne under the tutelage of Drs. Christopher Love and Darren Katz. And within his practice scope of sexual medicine, he has further interest in the LGBTQ plus sexual health. Our second speaker is Dr. Jake Miller, who is currently a third-year resident physician within the Department of Urology, also at the University of California, Irvine. He completed his undergraduate training at Northwestern University and his medical school at the Feinberg School of Medicine. He joined the urology department at the University of California, Irvine, where he has remained active in clinical outcomes research. And his medical research includes a focus on the use of oral testosterone replacement therapy, factors predicting satisfaction following the TRT, and treatment of erectile dysfunction in men who have sex with men. And last but not least, we have a celebrity here with us today, Jim Walker, aka Dallas Steele. Is a man of numerous talents. So he was initially a television news anchor reporter and worked in Bakersfield, California, Dallas, Texas, Fresno, California, Houston, Texas, and Fort Myers, Naples, Florida. And during his 24 years in broadcasting, he was nominated for 2 regional Emmys and won 2 Golden Mike Awards plus 6 Katies. He then transitioned to the adult industry. And in the gay adult movies, he has made more than 80 commercial scenes for numerous websites, and he has won 2 Grammy Awards, 22 Ravens Eden Awards, and has been nominated over the years for 8 Gay VN Awards. And he currently lives in Palm Springs, and he has a penile implant, and you can read an article in Men's Health magazine where he discusses his journey with the implant, and it's touched a lot of people who potentially were embarrassed or not comfortable about prosthetic surgery, and we thank him for what he does for other men with ED. So this is the program. These are the introductions. Then we're going to talk about erectile dysfunction considerations in the MSM population with Justin Law. Then Jake Miller will talk about penile prosthesis considerations in the MSM population. And then we'll have a 15-minute discussion between Chris Nelson and Jim Walker about penile prosthesis expectation satisfaction from a patient perspective. And again, here are our 3 talks. And I thank you for your attention. And we'll start with Justin going first.
Give me 1 second just to pull up my slides here. All right, can everyone see my slides here? Thanks for the introduction here, and thanks for the invitation to speak today. So we'll go through a quick overview of erectile dysfunction considerations in the MSM population here today. I have no disclosures here. As many of you probably already know, MSM stands for Men Who Have Sex with Men. Looking at our entire population here in the NANES study in 2001 to 2006, about 5.2% of the male responders actually identified as MSM, and but only about 44.5% of these men actually identified as gay or homosexual on the sexual orientation surveys. So it's very important in your clinical practice to ask not only about their sexual orientation, but also the gender of their sexual partners, because that kind of better guides your clinical decision making, as you don't have to necessarily be one specific sexual orientation to actually have sex with other men for male patients. As for ED in the MSM population, if you look at a study encompassing about 7,000 patients who identify as MSM, about 79% of patients in a generalized questionnaire will admit to about one or more sexual dysfunctions. This includes erectile dysfunction, premature ejaculation, etc. About 45% of these patients actually reported erectile dysfunction in this population. And then when we're looking at a meta-analysis, now here we're looking at heterosexual men compared to homosexual men, so not necessarily MSM, but more gay men in sexual orientation. We're looking at 4 different studies. Homosexual men actually have about a 1.5-fold higher odds of reporting erectile dysfunction. There's many kind of hypotheses about these. One major one is possibly psychological stress from social stigmatization, from being gay, discrimination, and also internalized homonegativity and shame. We know the psychogenic component is very big for erectile dysfunction and potential. Again, relationship and partner stability is also a really big one in the homosexual and MSM population here. Of course, as MSM kind of inherently implies, you're comparing yourself with the other partners, potentially leading to insecurities and potentially competition between partners as well, which of course drives that psychological stress as well. Looking at predictors of what might predict for erectile dysfunction in a patient who identifies MSM, Dr. Schindel and his cohort there in 2012 looked at about 2,700 patients who identified as MSM, administered the IIEF questionnaire, and then using multi-variable logistic regression, found that several predictors in this population actually predict for erectile dysfunction in this population. One being older age, HIV positive status, lower urinary tract symptoms, surprisingly, which was not reported previously, prior ED medication use, and a lack of a stable relationship or partner can be predictors for erectile dysfunction in this population. Now, they go into a little bit more detail why HIV status is possible predictor. Hypothesis could be androgen deficiency, as this is quite common in patients who have HIV. Immunosuppression possibly, and possibly retroviral therapy as a cause for erectile dysfunction as well. When evaluating patients for erectile dysfunction in the MSM population, it's very important to assess for the practices and preferences. Now, just going into a little bit more terminology for people who might not know, a sexual position is very important. It's not as typical, not usual as just a penis going into a vagina. There's different kind of interactions between partners. There's insertive intercourse, which commonly is also known as top, receptive intercourse, receptive anal course, intercourse, bottoms, and both. If a patient performs insertive and receptive anal intercourse, that's usually called versatile. It's very important, again, also to talk about the preferences of the patients as well. How important is it to have a rigid erection for their preferred sexual activities? For example, do they have, they could be potentially a bottom or perform mostly perceptive intercourse, but it might be important for them still, even without needing to penetrate, to have erections. Their desire to have erection can be more than just pleasing their partner. It can be for imaging, self-image, masturbation, oral sex, etc. So there's many reasons why a person or patient in the MSM population might want to have erections. So it's good to really elucidate and ask your patients that. And of course, a sign of masculine or a sign of arousal is of course another big thing to consider in a lot of these patients for erectile dysfunction. For ED treatments in the MSM population, it's pretty similar. There's not much difference in terms of the treatment compared to men who have sex with women. There are a couple caveats that you should probably consider at least. The psychogenic component is quite big, as I just kind of addressed earlier. It's definitely very important to address psychological stressors, social stigmatization and shame, like we talked about, relationship instability in patients who have multiple or unstable partners. And of course, with a lot of discrimination against LGBT populations, self-esteem and body dysmorphia can be pretty prevalent in the MSM population. So definitely referral or contact mental health providers can be very beneficial in this population. Asking about recreational drug use during sex is also a very big thing to definitely cover during your consultation with MSM populations. Something also called SMSNA or party and play, PNP. There's a lot of different terms of this, but it's quite prevalent in the MSM population. About 10.3% of MSM actually report chemsex use within the past 12 months. So quite a significant incidence and rates. And in those specifically who perform chemsex, definitely want to single out, or not single out necessarily, but identify patients who abuse stimulants like cocaine, methamphetamines, et cetera, because you want to caution and avoid use of intracavernosal injections and trimix due to priapism in those patients. So that's definitely a consideration that should be considered. And of course, penile prosthesis in patients who need or require a penile prosthesis for erections. I will kind of save that thunder for Jake Miller to kind of discuss that a little bit more. But in summary, again, MSM have significant rates of ED, especially those identifying as homosexual, gay. Definitely encouraged to ask about their partner's sexual position preferences to guide your clinical management, and of course, keep an open mind. Thank you.
Thanks, Justin. We'll go to Jake now, and we'll leave all the questions till the end. You can also put questions in the chat box or the Q&A box if you have any.
Fantastic. Can everybody see my slides okay? Okay, very good. Thank you again for the introduction, Dr. Yaffe. My name is Dr. Miller, and I have the pleasure to talk about penile prosthesis considerations in the MSM population tonight. To start, I have no financial disclosures relating to today's talk. As a brief outline for today's talk, we'll summarize some of the very key points discussed by Dr. Law in this preceding talk about the management of erectile dysfunction in the MSM population, specifically focusing on the use of inflatable penile prosthesis. We'll discuss the data or relative lack thereof regarding the satisfaction rates of MSM patients following IPP insertion. And then lastly, we'll discuss some of the considerations regarding the biomechanics and safety of IPP use. Looking more so at the first paper that Dr. Law mentioned, sexual dysfunction is incredibly prevalent in the community of men who have sex with men. One needs to look no further than the study that he mentioned from 2004, in which 7,000 men were surveyed for symptoms of sexual dysfunction. And again, in this study, over 79% of respondents noted at least one symptom of sexual dysfunction within a year's time, with 45% noticing difficulties with erections during this time frame. Of that total population for
Jake, you're frozen. We can't hear you. Yeah, for those of you who are attending, Jake is Dr. Miller is frozen for all of us, not just for you guys on your screen. So, so we lost Jake. We'll give him a minute since we're a little bit ahead of time. But if he's having issues logging on, Chris, we might just switch the schedule of the program and have you and Jim go on. It'd be nice to stay in the same order if possible, but if it's not possible, I think Jake is logging back on.
Okay, he's back.
All right, he's back. Wonderful.
All right, take two. So essentially, to leave off where Dr. Law just left his talk, erectile dysfunction is incredibly prevalent in the MSM community. And given this, one would expect a amount of research to have looked at treatment outcomes for this group. But unfortunately, the data in this area is relatively sparse. Some surveys, such as those listed here, describe that in general, about 16 to 29% of gay and bisexual men endorse some use of medications like Viagra or Cialis for assistance in initiating or maintaining erections. But how many of those men go on to seek IPPs for refractory symptoms? Now, this is not a computer glitch. Unfortunately, I did not forget to include a picture or text here. There's simply a drought of data pertaining to the rates of PDE5I failure and then IPP insertion in the MSM population. And then data pertaining to the outcomes of these men following IPP insertion is similarly sparse. After noticing the serious gap in the available data, our research team over at the University of California, Irvine, both Drs. Law and Yaffe, set out to investigate these outcomes. As our first stop, we wanted to see if satisfaction rates for MSM patients receiving IPPs were comparable to historical data. To answer this question, we created a multi-center survey, which included 7 high-volume surgical centers spanning across 5 different countries. Patients were included if they self-identified as MSM and had received either an AMS or Coloplast implant. In addition to operative and demographic data, we surveyed the respondents regarding their overall satisfaction following treatment using 2 questionnaires: the Erectile Dysfunction Inventory of Treatment Satisfaction Questionnaire, or EDITS, and the Quality of Life and Sexuality with Penile Prosthesis Questionnaire. Despite having 7 centers across 5 different countries, we were only able to recruit 49 participants, which highlights some of the difficulties in conducting some of these studies and the need for likely some initiatives like the recent multi-center pump collaboration to conduct further research. Out of these 49 participants, 21 were primary implantations, and no postoperative infections were seen. Only 1 revision was performed during the average 15-month follow-up period due to a non-infectious complication. In our cohort, the median EDIT score and quality of life score were 93.2 out of 100 and 72 out of 80, signifying a very high level of treatment satisfaction overall. When comparing this to historical data in the overall population of men receiving IPPs, these rates exceed the traditionally quoted satisfaction rates. Now, in discussing some of these findings, the authors noted that significant rates of treatment dissatisfaction oftentimes come from complications and specifically from device malfunctions. Just as Dr. Law mentioned, they postulated that device malfunctions may be of particular concern in the group of men who have sex with men, as rates of penetrative anal sex, while not the most common type of sexual activity in the MSM community, are higher than that for heterosexual men. Specifically, given the difference in sphincter muscle tone and pelvic floor muscles, it was suspected that stronger forces may be applied to the prosthetic during penetrative anal intercourse, and may over time cause trauma or predispose the device to malfunction. As such, our group next sought to investigate the historical data pertaining to the ability of IPPs to withstand varying forces and to determine the force which would be required for penetrative anal intercourse. The largest applicable study in this area is that by Ansari and colleagues, in which 100 patients status post IPP insertion were asked to inflate their device and hold a force-sensing pressure pad to the tip of the penis until either the device buckled or maximum force was reached. Varying device models were tested, and overall kinking of devices was noted to begin at axial forces or pressures applied to the glands that were in parallel with the penile shaft, as low as 980 grams of force. A similar study was repeated by Henry and colleagues, with a small but important variation in their methodology. In this group, devices were tested twice, once after they were inflated by patients, and then once again after inflation was performed by a prosthetic surgeon. In this smaller cohort study, the average force at which devices began to buckle in the patient-inflated series was 1,500 grams, with about 70% of device buckling during testing. Interestingly, though, no devices buckled when inflated by the investigators. Now, notably, some other studies have been performed using both cadaver models and ex vivo studies, with the former design showing the most promising results, with prostheses withstanding up to 6,100 grams of force prior to buckling, and the latter typically showing less favorable outcomes, with lower forces between 5 to 8 newtons in general being required for the kinking of device cylinders. Now, from these, we can determine that in patient-inflated studies, device kinking may occur at pressures around 1,500 grams of force, with more reassuring results again being seen with proper inflation technique. But how does this compare to the forces needed for sexual intercourse? Unfortunately, we can only answer this question halfway using a study from the 1980s by Kerrigan and colleagues. In this study, which has very little data published about its methodology and results, a force sensing gauge was attached to a plexiglass rod and inserted into the vaginal canal of an unknown number of participants. The forces recorded on vaginal insertion in the study were around 500 to 1,500 grams, which tended to be lower than that required for device buckling. But how does this compare again to penetrative anal intercourse? Our group recently sought to investigate this question in a study of our own, in which we designed a similar device using a silicone rod in the dimensions of the average US male phallus and a force sensing gauge. We inserted the lubricated device into the anal canal of 6 male participants for a total of 5 measurements each. On average, the maximal force required across 5 penetrations was 30.3 newtons, or around 3,000 grams. In other words, 2 to 6 times the force noted on vaginal penetration in that 1985 study. When separated by demographic information, participants who engaged in less frequent receptive anal intercourse had higher average forces at 4,200 grams compared to 2,600 grams. Not only do some of these forces recorded greatly exceed that historically as being required for vaginal intercourse, but they also exceed some of the forces at which IPPs have been noted to buckle in both in vivo and ex vivo studies. Most importantly, the forces for anal penetration exceed buckling forces recorded in those studies for which patients, rather than prosthetic surgeons, inflated the device. And so in summary, what does this data say about the use of IPP in the MSM community? Overall, despite a clearly high prevalence of sexual dysfunction in the MSM community, little is previously known regarding the outcome of IPP in this group. Newer studies are currently investigating these missing data, with recent projects from our own group showing that satisfaction rates of MSM closely match, if not exceed, those for the overall population. However, other data suggest that while IPP are likely an appropriate treatment option for these men, special counseling may be needed for patients, MSM or otherwise, who intend to engage in anal penetrative intercourse, given concerns relating to a potential risk of device buckling. Furthermore, these patients may need additional counseling regarding the appropriate inflation of these devices, given a large disparity between those studies in which investigators performed inflation. Overall, more data is clearly needed in this field. And while we at UCI hope to continue our own investigations, I hope this presentation has inspired some of you to consider your own investigations as well. Thank you again for your attention tonight, and here are some of my included references for further reading.
Thank you, Jake. I think, Chris, just before we get to you and to Jim, Justin, if you can take that question. So Dr. Perlman, who is a prominent urologist and sexual medicine specialist and part of the SMSNA board, has a question for you. Can you provide sample questions that we can ask patients when we want to better understand how they have sex in ways that are socially and culturally sensitive?
Yeah, I think that's a good question. Thanks for asking that. I don't have actual example questions, but I generally, in my practice, I keep it pretty simple. Most of my patients I ask, do you have sexual intercourse with female or male partners? And then if it's only females, then we leave it as that. But if it's male, then I kind of go into a little bit more detail. It's like, what are your sexual preferences in terms of What's your sexual positioning? Are you a top, bottom, verse? How important are your erections with, in regards to your sexual activity with your partners? And usually they'll kind of delve into that a little bit more. And then you can kind of see really, how important are their erections? Are they not really important? Are they important? But usually most patients, when they come into your door for ED issues, probably going to be important. So, but yeah, that's kind of how I approach it, pretty quick and simple.
And Dr. Perlman makes a good follow-up question, which I thought about at the same time that you were answering, Justin, is what about males who have anal penetration with females? Obviously, we don't have the data for what's required for anal penetration in female partners. But is that something that you think should be included in the intake questionnaire?
Yeah, good question. The thing is, with female partners, usually it's with aid of a toy. So generally that's not much of an erectile dysfunction type of topic. But I think in sexual intercourse and preferences, I think that would be definitely something that can be important to, figure out how to best help a patient enjoy their sexual kind of preferences and activity satisfactorily. But I think from a urologics perspective, I don't know how often I would ask that, but I think of course, if you're kind of all encompassing sexual health, I think it would be important to actually include that, especially if they have like anal dyspareunia, pain with penetration, but they also enjoy it too. So, but then that kind of gets into a lot of pelvic health and all of that. So as a urologist specialist, I don't get into too much detail on that, but definitely if you want to kind of encompass all of sexual medicine, definitely something to consider discussing.
Chris, you can probably give us the best perspective from your end about should we be probing more even in men who have sex with women about how the penis is being used, and what's your take on how the question and the intake should be in both the MSM and the men who have sex with women with regards to sexual preferences?
And that was questions for me, right?
Yeah.
I think the key is really just their comfort level in talking about it. And so, comfort level, and you're talking with men who have sex with men, comfort level asking, are you a top, are you a bottom? Are you versatile? Tell me about some of your experiences. I often ask about relationship status, and then if there's a relationship, kind of what the, is there sex outside a relationship allowed or not? Is that different than what's happened in the relationship? And so I think it's the comfort level that's important. And then translating that to heterosexual relationships. Certainly it's always beneficial really to ask kind of what's happening. If you're talking about erection, what's happening with that erection, right? And is it vaginal penetration, anal penetration, and clearly kind of the strength of a erection it's going to make a difference, right? And if someone's coming in for treatments for erections, it's really important to know kind of what they're using that erection for sure.
And I would add that if you are, and naturally some physicians might be uncomfortable asking the questions. I think if you can prepare an intake form. That way you don't have to, ask the patient when they're sitting in front of you. Just have them fill the intake form, and that way you have the answers ahead of time. I think if the patient is comfortable answering, they'll answer it. If they're not comfortable, they'll leave it blank, and then you'll have an idea about how they feel. And then one more question before we go to the back and forth between Dr. Nelson and Jim Walker. This is also from Amy, and this is for you, Jake. Great presentation. How should surgeons specifically counsel MSM patients prior to implant surgery when it comes to additional force needed for anal penetration? What might that 20-second message look like? I'm timing you.
Like everyone's been saying, it's what types of practices we're expecting these patients to engage in afterwards. If they are planning MSM or otherwise to engage in penetrative anal intercourse, I think it could potentially be reasonable to say there's small data that might suggest that there's higher forces that could be exposed to the device. And while we don't fully understand them, it's possible that this increased trauma over time could raise a risk of a device malfunction. And I think that leads to a situation where you can explain these are the types of things that you might want to look out for. If you notice any issues with intercourse or any changes in symptoms over time that you might want to reach out to our team about. And then specifically in the first post-operative visit, when you're considering inflating the device, I think it's very, very important that you sit down and not only demonstrate how to inflate the device for the patient, but also have them repeat that same practice with you in the clinic to ensure that they are inflating the device both appropriately and to its maximal extent.
Thanks, Jake. So we have a couple of questions more, but we'll answer these, I think, after the discussion with between Chris Nelson and Jim Walker. So all you guys.
Yeah, great. Yeah, thanks, Fasil. And Justin and Jake, really great job. Excellent presentations. Really enjoyed listening to those and really beneficial. So so Dallas, you're muted right now. I think you are anyway. Let's see, you're still muted.
You're muted, Jim. At the bottom, it's unmute. Bottom left.
There we go.
Hey, okay, all right. Yeah.
Yeah.
So first of all, no, do you go by Dallas or Jim? What should I call you?
You can call me either. Either is fine. I get addressed by all kinds of things.
So Dallas, so thanks for joining us. And I think
yeah. I mean, it's a pleasure. I was part of Dr. Miller's study that he just talked about, and actually came to our home and tested a number of volunteers that I managed to secure in Palm Springs. So I was happy that we could be part of that study and help with this.
That's great. It sounds like you might be a go-to guy for help with that type of research.
Well, I tell people, I get probably 30 to 60 emails a week from guys all over the world that say, you're the only person I actually know that I can message via Facebook or Instagram or Twitter who has an implant. You're the only person that I feel like I can talk to. There's a lot of guys who I know will not even talk to their primary care physician, much less, make an appointment with a urologist or a specialist. So in a lot of ways, I'm a lot of people's first contact with this, and I'm happy to do so.
Yeah, and that's great. And it's so important, right? To help.
Absolutely, because I don't think, like I said, there's a lot of fear out there. Dr. Yaffe mentioned about people in pre-screening answering questions. A lot of people are not willing necessarily to acknowledge first that they have a problem. And the second thing is they don't know that there are solutions out there. And like the Men's Health story that I did with Dr. Yaffe, I got probably 300 emails from guys just, oh, I didn't know this option was out there. And I always point out to them that, that an implant is a progression after oral medications and certainly injectables. But it's one option that's out there in the string of options. But there's no reason for most men, I always convey, for your sex life to be over.
Yeah. And those men who reach out to you, are those primarily gay men, MSM men, or straight, or?
Yeah, I mean, my audience with gay porn is primarily gay men. I mean, I do have some that are bi and that type of thing, but by and large, they're telling me that they have a problem. They are not sure what to do about it. They heard about the story in Men's Health, or maybe they saw me actually demonstrating it in a video, and they're like, "Wow." I did a video 2 weeks ago with another implant recipient, a patient of Dr. Perito's. And it was the first time I personally had ever been with anyone else who had an implant. So it was kind of a learning experience for me, but that video is up there and it's been out for 8 days now. And there's been a lot of really good feedback from men who are like, "Oh, wow, that's amazing." So that's been very affirming in that sense, that I can help that way.
Yeah. And so maybe just tell us a little bit about the, kind of the journey through these treatments that you talked about, and how it's impacted you in your life.
Yeah, I think I started having trouble about 28. And some of the factors that Justin mentioned in the intro are true about me. HIV positive, sex, I do have sex with my partner, but also obviously I have sex with others. That's a factor in there as well. When I started having problems in tried orals. They work somewhat, somewhat not. And then when I started porn 10 years ago, trimix became a pretty much everyday thing. And the industry, as you well know or may know, doesn't always talk about its excessive use, but they say they don't condone it, but if things aren't working, you won't be asked back. So there's a lot of pressure to use injectables. And I was at some point in my first 5 years doing movies where there were days where they wanted you to keep going for 7 and 8 hours with 2 to 3 shots in a single day. And over time, that started to do damage. I think when I first saw Dr. Yaffe 4 years ago, I was starting to lose sensitivity on one side, was developing a bit of a curve. And that's when he had suggested the possibility of an implant. And so went through that procedure. And I have to say, I've been entirely satisfied with it. It's been wonderful. It's not without its challenges. You were talking a second ago, I think Dr. Miller was saying about limitations of the device, especially for anal sex. There are certain positions that I try to stay away from. And, I tell guys, basically, if you have an implant, respect your device. Respect your device. Don't do something that, inherently seems like it might not be a good idea. For like a tight ring around it, a constricting ring, or something that puts pressure on the apparatus, not a good idea. And there's certainly positions that are problematic that I won't do. So it's something to be conscious of. I think as time goes on, everyone's like, well, how long is it going to last? When will you have to have a revision? I said, I don't know, but I'm not particularly concerned about it. I have confidence in my doctor. I have confidence in the product. And when and if that happens, I'm good with it.
Yeah. And I think, it's interesting. You talk about positions that you might stay away from. You're kind of respecting the device. And so you talked about constriction rings, things like that. But are there what are those positions you stay away from, and what?
Yeah, I mean, one of the big ones is reverse cowboy or cowgirl if in the other population. That seems to put a lot of pressure. It's uncomfortable, and it seems like it might be inherently dangerous. So try not to do that one, or a position to where the receptive partner is on top of you and in a squatting position. Obviously you hear stories of men, I say mortal men, who have not had the procedure who end up injuring their penis that way. That's pretty common. And, you can injure an implant in the same way. So I don't like that either. Those two are the ones I stay away from.
Right. And, following up on Jake and Dr. Miller's presentation, in terms of, I with the assumption that you're a top at sometimes and you're inserting.
Versatile. Yeah.
Yeah.
I'm versatile. Yeah.
Yeah. And versatile, right? And so have you ever had any difficulties with insertion? Has you ever thought boy, it's the implant's buckling, or?
Yeah, I have had that, as he mentioned, particularly with partners that don't commonly have receptive anal sex, or they're new to anal sex. That happens to where there's just so much constriction that I have had it start to buckle. But that's when you say, all right, we need to back off of this and try a different way, or start slower, or something else. I would never force it in, because again, that doesn't seem like a good idea for either party.
Right, sure.
Yeah, one other thing I tell guys when they message me is I don't like the word prosthetic. And I prefer to use the word in the Men's Health article, bionic, because bionic makes you think of, and some of us are old enough to remember Steve Austin and the $6 Million Man. Guys like the idea of bionic. That sounds strong. It sounds like the Transformers, all of that. And when you use that verbiage instead of prosthetic, they look at it differently. Mm-hmm. And I have guys who message me, well, tell me about your disability. And I said, well, I don't know about you, but I can do things you can't do. I can go longer, more often, whatever. So explain to me how that's a disability. And that kind of shuts that down. They don't have much to say about it. But I think part of what happens with guys who have implants is how they feel about it. how do they present it? If they're feeling shame or they're uncomfortable with it, I think that comes across to partners. But in my case, whether it's for a movie or a partner one-on-one, I've had whole circumstances where I've gone through 2 or 3 hours with someone and they never even realized that there was an implant there. And because I found ways of integrating inflation of the implant into the sexual process to where they don't even notice, they don't even know, and maybe that's just me being sneaky, but I tell guys, it's not a process to where you have to stop sex, you have to integrate it into the process of going into sex. And so I talk about a lot about how to do that with guys, and they seem to like that it doesn't have to be a stoppage. You just make it part of the process, kind of like in the early days of HIV when we made condoms sexy, and this is how you integrate putting on a condom into sex. It's kind of the same process with the inflation of an implant.
Mm-hmm. So that's interesting because I've had a lot of patients who are gay men talk about how they integrate injectables into a sexual situation, how they do that, right? So, but tell us more about how you, what's your sneaky tricks on?
Well, nothing really all that sneaky. I mean, if you're kissing someone, you can reach down there while you're kissing them, or conversely, if they're giving you oral sex, pull that away from them for a second, bend over. When you bend over and kiss them, grab your pump while you're kissing them, let go of it, come back up. There's a little more up there, kiss them again, repeat the process 4 times, and you're where you need to be. And, they just think it's, you're kissing them and you're gradually getting excited. So it seems very natural through that process. In the instance where, they feel the pump down there, I'll eventually stop and I'll usually say, do you have questions? I'm like, feel free to ask whatever questions. And I have never in, 80 movies and more than 300 OnlyFans that I've self-created, had anyone who was disgusted. More than not, they're intrigued. Mm-hmm. They want to know more about this. They're like, or sometimes they're, a little like, oh, well, I don't need this. Obviously, I'm young or whatever. I'm like, maybe you don't, but maybe someone who does, or maybe you will in the future. But I've never had anyone who was just disgusted, who ran out or anything like that. People seem genuinely interested.
Right. And yeah, and it's it's important. The notion of being able to integrate it into a sexual situation that you called it sneaky, right? You can think about it as more spontaneous, or so many people call it more natural, right? Like how does it more like a more natural experience?
Well, people sometimes guys say, oh well, whether it's an implant or oral medications or an injectable, and they're like, oh, that's not natural. But meantime, they're on 5 other medications for various things. It's like, well, those medications are natural. So I think you kind of have to get past that particular concern that they have. And once they see how well it works, they're sold generally. I don't have to do a lot of convincing with it.
And so what advice do you have for us healthcare providers interacting with gay men,
I hear this where I live in Palm Springs. The major health provider in Palm Springs is Eisenhower Health. And what I hear from guys who see, and this is not meant to be pejorative against the doctors at Eisenhower, but what I hear from some of the patients there are that the doctors there really aren't concerned whether they're gay or straight. And I think to Justin's point, I think it absolutely is relative what you're using your implant for. I think that's important to ask. And these doctors don't really care. They're just like, well, you have a problem. And I had one friend who's gay who saw this doctor 4 times before implant surgery, and he kept asking about his wife. He's a gay man who's been partnered for 24 years. He's told you he's gay repeatedly, and you keep asking about his wife. That tells me that there's, not a lot of concern with some doctors at least, about finding out who their patients are and what they're using the device for. And I think that that's very important to have, not necessarily a gay doctor, but a doctor who understands concerns of men who have sex with men. I think that that's very relevant.
Yeah. And so I'm going to speak from my experience as a clinician in New York City. And so, I see there's a high population of gay men in New York City. And I would say, I don't want to give a percentage, but most of those men, and I deal with men with prostate cancer. And so they're generally in their 50s and 60s, 70s. And I would say most of those gay men are in committed relationships. And I would say most of those relationships are open relationships. I would say kind of a number of times that I've had patients who weren't having anal sex with their partner, but would go outside the relationship, open relationship, and then they would have anal sex kind of outside of the relationship with others. And can you talk about that a little bit from the gay culture? Is that something that's it's like it's
I think it's pretty common. I mean, if I were to hazard a guess, I would say probably 50% of long-term couples probably have extracurricular activities. I'd say that's probably a pretty safe number with different frequency. I mean, I know some couples that play with others once or twice a week. I know some it's once or twice a year. But I know the number's pretty high of the percentage that plays outside. In my own circumstance, I've been in a throuple for 8 years. I have one partner who's 14 years younger. I have another partner who's 6 years older. And my two partners are not romantic or sexual with each other. It's more like I have two partners or two husbands in the house. But we all live together, and sometimes we all end up with others together on vacation or things like that. And it works pretty well in that we kind of all know what each other wants out of an experience. And obviously I do movies, so that's another component, obviously, that I take part in outside of my relationship as well. So there's a lot going on there, but I would say a good percentage of couples play. And I think that's another important consideration is, if you are doing stuff outside of your primary relationship, whatever that is.
Yeah. And the reason I ask is a few things. One is normalizing that for kind of all the healthcare providers, that it's number one, it's important to ask, and number two, it's potentially part of gay culture, and not to be shocked or judgmental.
It absolutely is. I mean, as is what I think Justin was talking about with chemical use. That's another thing that comes up fairly often. And I hear from, gay guys, when I'm using this or using that, it doesn't work. Not a surprise. I mean, we've known for a lot of years how not only alcohol, but other drugs affects your erection. That's not a new thing. So it kind of always surprises me when I hear that. But as you said, chemicals are a part of gay culture and gay sex for a lot of people. That's a lot of people. And I always stress, it's like, don't make your use of substances or potential substance abuse a reason for you to get an implant. If that's your reason, that's the wrong reason. But I do hear that from time to time when I'm doing this, it doesn't work. Well, don't do that, But for a lot of people, they become so connected to chemicals and sex that they really can't have sex without the chemicals. Sad that happens, but it does.
Yeah. And Dr. Yaffe, I'll just stop here. You want us to keep on going with the conversation?
I think we have a few questions here, and including one that is for Dallas, so we can actually ask that to Dallas. So this was a wonderful conversation, and as far as I recall, Chris, you've been around SMSNA a bit longer than me. I don't think we've had an open conversation about IPPs and the MSM population like this before.
Yeah, I think this is the first.
Yeah, this is awesome. So Dallas, this is also a question from Dr. Perlman. She's got very busy fingers today. So she says, Thank you so much for sharing. How do you suggest we as healthcare providers, and this is kind of similar to what I think Dr. Nelson was mentioning, better engage with the MSM population? We have so many ways to help when it comes to ED, and yet we tend to not see a lot of these patients in our offices.
Yeah, I think a lot of times people who could benefit from IPP are not people who are necessarily going to show up at the office. And I'm not necessarily saying, you set up a booth at a gay pride festival, but it's not a half bad idea to answer people's questions. Or here's the other thing, perhaps some kind of outreach connected to, sites that gay men are at. I hate to say this, but, even like Pornhub, hey, having problems, there's help, something like that. In a way that is non-threatening, that people can reach out without actually having to see you face to face. And that's kind of what I get with emails. They don't have to see me face to face. They don't necessarily feel shame in asking me. It's fairly anonymous. Some kind of semi-anonymous vehicle where they can ask questions without having to feel embarrassed.
And Justin, a couple of questions for you. These are from Dr. Omar Rahim from University of Chicago, who is a fellow SMSNA member and high volume implanter. So he says, and the reason I'm asking you is you're the one who did the survey on the MSM population satisfaction with implants. The first question is, at what time post IPP you think we should start survey satisfaction? As in, how much time should we give it in terms of recovery, et cetera, before we start asking patients? And to follow up on that question, is there any published data on partner satisfaction in the MSM penile implant population, not just the patient themselves?
Yeah, good question. Thanks for that. So for the first question, I think the earliest time points we were doing were like 1 and 3, but I typically would say 3+ would probably be the best time point for survey satisfaction. I'll have to look back. I forget what the median follow-up time point for the surveys were, but significantly longer than that. But obviously, you have to kind of get over kind of the discomfort and pain and recovery, as we all know from the IPP recovery after surgery. So generally, at least 3 to 6 months. For the second question, to my knowledge, I do not know of any publications on partner satisfaction in MSM with IPPs. There are partner satisfaction with like ED in MSM, but not specifically to IPP. And then,
go ahead, Justin.
Sorry.
No, go ahead. Sorry.
Oh yeah, and I just kind of wanted to carry on Dr. Perlman's question to Jim about how can we engage people into seeking help for their issues. I think in the LGBT community, especially gay men, I think there's a lot of dependence on, hey, what do you take, or who are you seeing, or where am I getting this, or where are you getting this? There's a lot of also like underground things of like obtaining like direct to consumers and all of that. And so people kind of self-treat. I think a big thing in terms of getting outreach is of course, within your clinic itself, putting little tiny things is, like maybe like an ally kind of, or rainbow flag or whatever, something that kind of shows that, hey, you're a diverse and inclusive clinic. But also on a broader scale, there are different like physician directories. I know the GLAMA, the Gay Lesbian Medical Association, has a physician directory that you can sign up on, where patients can actually look up for specific providers that are gay, LGBT friendly, and that would be kind of a good thing to kind of do some outreach there.
Thanks, Justin. Amy asks, how long after IPP before having the patient use the device for anal penetration due to increased forces? So Amy, I do all my implants penoscrotal, so or the overwhelming majority. So I usually activate the devices or start cycling everybody at 2 weeks, but don't have them use it till 6 weeks. And I do the same for men who have sex with men. And usually I tell them when they start, don't try your personal best from the get-go. And I think most men are still a bit sore, and I think most men will in the beginning not, try to go too hard on the implant. That being said, we've all had patients who waited 3-4 days after getting the implant and the incision hasn't healed yet, and they're already used the implant and ended up with complications. limitations, but I would say that I do the same for men who have sex with men and men who have sex with women. So I don't change the protocol. I don't particularly think we need to change the protocol, but I think it's a good question. I think the most important thing is to really inform the patients about waiting, and then when they start using it, to be to know initially the limitations. But I think after a while, they're usually most comfortable with most positions. But I think we got a lot of good insight from Jim today about some of the limitations of the implant that maybe I did not consider discussing with patients. So I think this is the beauty of a webinar like this.
Dr. Yaffe, one of the things that people ask frequently of me is, can you still ejaculate? I mean, that's one of the concerns. And I think that some of that comes from the assumption that everyone who has an implant has had prostate removal, right? And so they assume that that's the case. I get that question all the time. Like, yes, that still happens for me. And I point out that not everyone who has had the surgery has had prostate removal, but I know that that's a common reason for it.
So we're gonna about 4 minutes left. Jake, I'll get off the hook this easy. So one more question for you. Any special counseling regarding men with penile implants to engage in anal sex when it comes to IPP infection risk?
So at least in our own series, again, with roughly about 50 patients, no infections were seen within the average follow-up time, which was between 14 to 15 months. With that being said, of course, I think we need a larger cohort and a longer follow-up time, again, to see if it does match the typically quoted 1 to 2%. We do have, and I briefly mentioned it in the talk, a larger collaboration, a multi-center database called the PUMP collaboration, where we're looking at larger outcomes for thousands of patients following implants. And within that group, we're actually going to try to look back and see if we have any meaningful data on sexual activities or sexual orientation, to see if we can pinpoint any changes in either complication rates, infectious or non-infectious, for these patients. And so hopefully more information to come, but at least in our own limited series, which to my knowledge is the only thing that really touches base on it in the published literature, there was no significant change in the typically quoted infection rate.
And I think the important thing is most infections occur early after penile implant surgery. So they mostly occur in the first 6 to 8 weeks after surgery. So, most of these patients have not been sexually active. I think once the wound is healed and you're out of the infections that may have occurred at the time of surgery, I don't think it should make a huge difference. I think obviously safe sex practices should always be recommended. But again, that is a debate for another time. And we've had that debate at the SMSNA before, whether us as prosthetic urologists should be also discussing safe sex practices with our patients or not, but that would take another hour on the call. So we've got another 2 minutes. So any closing statements? I think this has been wonderful. Jim, I'll first go real quick. Jim, thank you so much. This is really very beneficial to us, but also to a lot of patients, and the webinar is available online, so anybody can watch it at a later date. Of course, nobody could run a conversation better than you did, so thank you for doing this. And
thank you,
Justin,
I'm honored. Thank you.
And Justin and Jake, you make UCI proud, so thank you to both of you. But anybody else have any closing comments? We have 2 minutes left here.
I have a thank you to kind of all our presenters, and a last question for Dallas. Any kind of concluding remarks, any tips, anything you want to say?
Well, the thing that I say, first of all, to people who message me is see your urologist. I mean, that's number one. If you're having a problem, have the courage to go in and talk to someone about it. And a lot of guys just would rather suffer. And that's unfortunate because there's no reason to, and there are certainly a lot of options, not just implants out there. And so that's the first thing they say. And then the second thing I say is, if you get an implant initially, it takes a while for it to feel like yourself, but it does feel like yourself after a while. It does become part of you and is kind of integrated into who you are. I really don't notice it all that much. Conversely, I had a shoulder replacement surgery, so this is all titanium on this side just 6 months ago. You think a lot about it in the first few weeks after surgery because it hurts. But now I'm back to 80-pound dumbbell presses, full range. I don't even think that it's titanium anymore. It never occurs to me. Kind of the same thing with that. I never really think much about it. until, someone's like, what's that? What are you doing? And then I'm happy to stop and explain it. And I'm happy to be out there and public about it. As far as I know, the only porn performer ever, gay or straight, to ever be on the table about it. And I know other gay performers who have them. There are probably 8 others that I know quite well, but it's hush hush. No one wants to talk about it. I feel like, if I can use my 450,000 followers to help someone, I'm happy to do that.
Thank you, Jim. Justin, Jake, any closing remarks in the last 30 seconds or so?
No, I don't have any closing remarks, but thank you for the invitation. It was really, really good webinar. Thank you.
And thank you again, Jim, for being so open about this.
You're most welcome. Happy to do it anytime.
And on that note, on behalf of Chris and myself, thank everybody who attended, and especially thank Dr. Perlman, who should have been on the on the panel. And thank you for the SMSNA for doing these free webinars that are really helpful to physicians and patients. On that note, I wish you all a good night, and please join in on future webinars. You can go on the SMSNA website, look up SMSNA webinars, and there are various webinars pertaining to all kinds of aspects related to sexual medicine. Good night, everybody.
Good night.
Thank you. Good night.